Okay, sir. Very good afternoon to all. Myself, Dr. Madhav Dwivedi, and I am very good afternoon to all. Myself, Dr. Madhav Dwivedi here, Associate Professor, ISF College of Pharmacy, Moga. I am very thankful to be high dignitaries to present in this session. First of all, I welcome our Director cum Principal, Dr. G.D. Gupta, sir, Dr. Saurabh Kose, Head of Department, and Dr. Mehan, sir, and our guest, Dr. Ankit Gaur. I want to give some introduction about our guest of the today. He is a healthcare professional with 6 years of clinical experience and published over 20 articles in well-reputed journals, which has over 93 citations. Professional members of various bodies such as British Society for Antimicrobial Chemotherapy, Federation of Clinical Pharmacists in India, FCPI, International Society of Pharmacoeconomics and Outcome Research, India Pharmacy Graduates Association, IPGA, Society of Infectious Disease Pharmacists, SIDP, Society of Antimicrobial Stewardship Practices, Indian Red Cross Societies. Presently, Dr. Ankit Gaur is a clinical pharmacist, coordinator, medical device, adverse event monitoring center, coordinator, Kailash Hospital Healthcare Institute. We welcome you, Dr. Ankit Gaur, sir, for this session, and I want to give introduction speech from our director, sir. Please, sir.
Thank you very much, Dr. Madhavji, and I am thankful to the Pharmacy Practice Department for provide this opportunity to interact with all of you. So, first of all, today's expert, Dr. Ankit Kumarji, so from ISF College of Pharmacy, being a director, from core of my heart, I welcome you, sir. I also give the lot of good wishes and congratulations on the occasion of the 79th Independence Day. We are celebrating in the huge manner and throughout the country, and our buddy Prime Minister given on the speech 10 important points for the growth of the you can say India, as well as one of them is the healthcare system, digital. This is the one of the most important part, and obviously we know that healthcare system is the important component of any country. So for this purpose, pharmacy practice is doing the excellent job role. Dr. Saurabh Koseji is the always dedicatedly and full of enthusiasm. He involved in the various activity, and because of this reason, we are going to the organize one of the. This is the very important of this workshop on the online mode. On the title is the good pharmacy practice, and today's title taken by the Dr. Ankit Gaurji. This is the good pharmacy practice principles into the action. So obviously today is the theme of the even independent day. What is the action? So without action, if we can only the planning, these things is the not sufficient of any types of the outcome. We are when we are discussing about the NEP, National Education Policy. On the basis of the National Education Policy, they want to involve the PharmD program, M-Pharm pharmacy practice direct related to the health profession, so that some of the burdens of the health profession it will the reduce, and they can be also work shoulder to shoulder with the doctor, so that it will be the comfortable to the patient. And I hope that today's talk it will be the very helpful to the each and everyone. Whatever you have the planning in good pharmacy practice, what types of the practices the routinely we are the doing, and how we can take the action, and what is the principles of the GPP. So we can go through the study on the just on the you can say number of the books available. What practically knowledge is the sometime very important, because we know that each and everything it can be, if required no required the practical training, then everything it can be complete the bookish. But I know that our elders they are not highly educated, but they have the lot of experience. Because of this reason, they are more technocrat, more you can say even the no degree, what they are the too much practical in their life. So thank you very much, Dr. Ankit Gaurji, for accepting our invitation and provide this opportunity to our department, PharmD program and pharmacy practice program for this workshop, and accept you have accepted our invitation at a very short notice. So I hope that today's talk it will be the very helpful to each and everyone. And if any student want to ask the question, there is a two mode of the online platform. One is the Google platform, so only the selected participant they have the connected through the Google. Another platform we are have the online mode. This is the live YouTube. So any person want to the ask, you can send on the chat box. It will be the taken accordingly, and our team member try to give the answer or reply with the help of the expert online, or you can say in the form of the live. If any question is the remaining, our team member will be discuss and give the reply. So maintain the decorum, maintain the definition. Again, आप सभी को, आपके परिवारों को, भारत के प्रत्येक नागरिक को और खास तौर से हेल्थ प्रोफेशनल्स को 79वें स्वतंत्रता दिवस की हार्दिक तहे दिल से शुभकामनाएं। श्रेष्ठ भारत, सर्वश्रेष्ठ भारत, विकसित भारत बनाने में भूमिका निभाएं। ड्रग फ्री भारत, स्वस्थ भारत में अपना अहम योगदान दें, ऐसी मैं सभी से कामना करता हूं। थैंक यू।
Thank you, sir. Now, Dr. Ankit, please start your session. All digital dais is yours.
There is something technical glitch. He is just returning.
So, as you know that good pharmacy practices are the requirement of the time, and in Indian pharmacy practice, you can know that community pharmacy, hospital pharmacy, clinical pharmacy, online pharmacy, Jan Aushadhi Kendra, there are a lot of sectors are going on. So our speaker will be joining very soon. Till that time, we can just go with the session that how many of you know that India has how much number of pharmacists? So in India, there are total 20 lakh pharmacists, 20 lakh outlets. Out of 20 lakhs, there are 15 lakhs community pharmacists. In India, the ratio for the pharmacist is on 1700 people, there is one pharmacist. And if we talk about the physicians, 11,500 people, we have one physician. If we talk about the nursing professionals, 493 people for one nursing staff. So the paradigm shift into the medic and the paramedic staff is just to look after the life-saving profession. So pharmacy, not only pharmacy, but nursing, airline pilots, firefighters, as well as this another one which I told, pharmacy. These 5 professions are the one which save the life of the individuals. So God cannot be everywhere, so they have put it this paramedics and medics, the people who save the lives. So pharmacy practice, in apart from pharmacy practice, if we discuss about other types of practices like clinical practice, then physiotherapy practice, then you go with the nursing practice. So medical paramedical team make a move for the patient care, and then they came up. So these are the various crux of the time in pharmacy practice. So now I would like to request Dr. Ankit Gaur, he is with us, so to share the screen and start the session. You can unmute yourself, Dr. Ankit, please.
Am I audible, sir, now?
Yeah, now you are audible.
Okay. I will start sharing screen. Thank you so much, sir, for giving this me opportunity, and I wish you happy, tremendous day to all. And without delay, I will start with my presentation. So let me know if my voice breaks out or if you're not able to hear me. Just let me know, okay?
Okay, we will be vigilant.
Okay, sir. So now good pharmacy practice principles into action. So the goal of this presentation is about teaching you how you can implement these practices in your daily life and how this is going to implement uh, the safety protocols or the policies that we follow, but which you can put into your practice and you can enhance the patient safety. So I will start with the definition first of the good pharmacy practice. So good pharmacy practice is the practice of pharmacy that responds to the needs of the people who uses the pharmacist service to provide optimal and evidence-based care. It simply means that the good pharmacy practice is all about providing care to the patient based on the evidence which is available to you and ensuring that they receive the optimal treatment based on their individual patient needs. So it is similar to the pharmaceutical care. And the good pharmacy practice talks about the ethics, the confidentiality of the patient. It talks about the quality control, quality assurance, how you can do in your practice, things that you have to look after, the roles that you have been given, and how you can fulfill them. So this is all about this. The principal practices are there about it. So good pharmacy practice states that a pharmacist first concern in all settings is the welfare of the patient. Number one is that we should be concerned about the welfare of the patients. And second thing is that the core of this pharmacy practice, all of these activities should be centered around the patients, and we should utilize the resources which are available to us to ensure that uh, they receive the best optimal care, which is of the assured quality, and adequate information is provided to the patient regarding the administration of medicine and the counseling and everything. With also we should inform the patients about the monitoring of the effect of the medication that they are taking. So two major things that we have to make sure. First is the welfare of the patient. A second is how our services are going to provide them the benefit. So this is good pharmacy practice is all about. Second thing, GPP says that the pharmacist's contribution should be a part of the team. Second, it should promote safe, economical, and rational prescribing and dispensing to the patients. So, as clinical pharmacists, we are involved at the various levels of the patients in the hospital. So, we ensure that the patient receiving safe, rational medicine and which is prescribed on the economical basis as well. So good pharmacy practice also requires that the each element of the pharmacy service is relevant to the patient and the roles are clearly defined and there is a collaboration from multiple healthcare professionals. Like for clinical pharmacists, we collaborate with the nurses, the consultants, the RMOs, to doctors on the wards. So we collaborate with each one of them and we deliver the best care to the patient. And all of these care are centered around the patient only. So what is the underlying philosophy of this good pharmacy practice? Number one is that the pharmacist should be readily available to the patient with or without appointment. Number second is that we should identify and manage or triage the healthcare problems and we should promote the health in the patients as well. Number three is that we should assure the effectiveness of the medicines. How we can do it? Like we can assess the patient case. We make sure what is their need, whether they require any dose adjustment, is there any hepatic impairment, is there any renal impairment. So we provide them the effective treatment, modifying their dose, ensuring that these doses are safe. It prevents them from harm from the medicine, and we ensure that the treatment outcomes are good. So that's how we use this good pharmacy practice into our daily life. The sixth thing that this philosophy talks about is making responsible use of limited healthcare resources. So in our hospital or in any hospital, the resources are limited. There is a limited budget. There is a limited thing that you can do in the hospital. So you have to make sure that whatever activity you are doing is utilizing that limited healthcare resource. And the scope of this philosophy can be from community, hospital, clinical, industrial, or any pharmacy service. So we utilize good pharmacy practice in all aspects of the pharmacy services, whether it is community, hospital, clinical, industrial, or any other specialty pharmacy service. So few frameworks are there to make sure that the principles of this good pharmacy practice are followed in throughout the world and in India as well. So FIP, Federation of International Pharmaceutical Association, and WHO, they have given joint guidelines on good pharmacy practice. So if you want to study more on this topic, you can go and search for these guidelines. Then you can check it. And in their joint guidelines they have shared few principles and what should be the good pharmacy practice should be all about. And in India there are some legal frameworks, such as Pharmacy Act is there, how you can implement, how you can get the licensing of the pharmacy, what are the requirements, what should be the space, who is going to dispense the medicine, what is the registration process, who is going to be the qualified personnel, everything is defined in this. And Drug and Cosmetic Act is also there to ensure that the safe and rational use of medications is going on in the society. And to govern our practice, some H1, Schedule H, H1, X control are there for narcotic prescriptions, psychotropic substances, or medications which require prescriptions. So, for practices, these laws are there. For controlling narcotics, the NDPS law is there. And for governance, CDSCO oversight is there. PCI has given their standards. If you work in the hospital, in a private hospital, there are guidelines given by the NABH, and some hospital SOPs are also there, and the pharmacy practice regulation is also there. So for Indian context, if you are talking about, you have to deal with many things such as CDSCO, PCI standards, NABH guidelines, your hospital guidelines where you are practicing, and last one is your pharmacy practice regulation. But pharmacy practice regulation is not implemented throughout the India. It has to be implemented state wise. Few states have implemented it, few states are going on to implement it, but it is a long journey. So good pharmacy practices, they have in these laws they have given few things. Number one is they have defined the roles and responsibilities, such as who is clinical pharmacist, who is hospital pharmacist, what is the definition of clinical pharmacy, hospital pharmacy, community pharmacy. Each definitions are have been given in these laws. Second, they have given what should be the qualification of the practicing pharmacist and whom they are going to report, what will be their roles and responsibilities, what are the basic aspects, what are the basic things that they have to fulfill. Everything is mentioned in the pharmacy practice regulations as well. So the WHO and FIP has given some GPP principles for implementation in the hospital. It gives four roles. GPP has four roles in various stages. So number one role is about provider of medicine. So provider of medicine, the whoever is providing the medicine, they have to ensure that the medicine which is available of quality, it is available at all times, and the safe supply line is there. So supply chain management has to be there. So example is that they have to verify the supplier's credential, and they have to check the batch and expiry and the integrity of the supplier. That supplier is giving the medicine all the time, and there are multiple suppliers available. If you want to source a particular salt, if one supplier is down, then you can take medicine from another supplier. And all of the suppliers are adhering to your quality standards which you have defined in the hospital. Second is the provider of care patients. So as a pharmacist, second role that we do is to provide the patient care. So what patient care we are providing? As clinical pharmacists, we are optimizing the therapy, the outcomes, and we are doing this by performing medication review, counseling of the patient at the discharge, and we are also doing prescription audit in the hospital. So what we do in the prescription audit, we see the case, we analyze the prescription on certain parameters. There is a checklist. We use that checklist to make sure that all the details are available, whether the doctor name is there, which ID is there, patient diagnosis mentioned, whether drug 6 hours of medicine, patient's route, dose, frequency, time, and the dosage form, everything is mentioned or not. Second, whether it is up to the patient's clinical condition, we correlate it, whether the patient has any hepatic or renal dysfunction, does the patient require any dose adjustment. So based on that, we analyze the prescription OPD basis on the inpatient basis as well. Then we perform the medication review, and we also counsel the patient whenever they are in the hospital and when they are being discharged. So we counsel the patient on their medical condition, the medicine how they have to take, what are the side effects, what is the action of the medicine. On each and everything, we provide them the information. And the third role that GPP talks about is the trainer and the supervisor. So, as in the hospital, one of the responsibility that we have is to train the doctors, nurses, and the consultants, and also other hospital staff which is working in the hospital, such as floor managers or the housekeeping, ward boys, ayas. These are employed, which all of them are employed in the hospital. So we have to do them their training. We provide them the education through the seminars, workshops, and the public awareness campaigns as well. So we build their competency. We train them on the certain aspects like how you are going to work on with the high risk medications. What are the standard practices that you have to follow? What are the policies related to chemo medicines, what are our policies related to narcotic medicines. So all of these things we talk about, and we train the healthcare professionals in our hospital, and we check for the various parameters such as adverse drug reactions if they are reported to us, the pharmacovigilance activity, the medication errors, they are reported to us, we check them as well, and we take action based on the medication errors, and we present this data in the infection control committee or drug and therapeutics committee in the hospital. So this is our third role, and fourth role is about the influencer in policy. So by learning through our adverse drug reactions, medication errors, or the daily practice that we do in our hospital, we use this knowledge to influence the policy. We make policies related to medication management, and we implement this in the hospital. So this helps making in a safer systems, and we make sure that these systems are followed and everything is in place so that patient harm is not there. How we do it? We use these proposals in the Drug and Therapeutics Committee. We present the data of drug utilization, and that's how we make policies. We influence the prescribers, and we make policies and implement in the hospital. So medication management from procurement to dispensing. So whenever I am talking about this, it means that the medicine, as a clinical pharmacist, one of my major responsibility is to make sure that the medications are dispensed or used in or in the hospital are based on the formulary. So we have drug formulary in our hospital, and whatever medicine we are using, it is entered in the formulary. And if we are adding a new medicine, then we make sure that this is entered in the drug formulary. But before entering this in the drug formulary, we do the discussion in the Pharmacy and Therapeutic Committee or DTC, Drug and Therapeutics Committee. So in this committee, we discuss on the molecule which is available to us, what are the companies which are supplying this molecule, and what is the safety profile, what is the pharmacoeconomic point. Suppose, let's say, if I am going to introduce ciprofloxacin in my hospital, ciprox brand is there. So ciprox brand, three alternatives we have already available with us. But if we are going to use this brand in our hospital, what is the basis? Let's say, if the pharmacoeconomic cost is low, if the cost of this brand is low compared to other brands, then we can use it, and we will present these findings in our DTC committee. Then we will discuss the profile of this drug, the vendors which are available, the safety profile of this medicine. Then we will include it in our formulary. And The drug formulary is basically prepared based on the essential list of medications. So in India, we have essential list of medication based on WHO, and Health Ministry has also provided it. So all of the medicine which are available in our pharmacy, most of them are essential medicine. Apart from essential medicine, whatever medications we are using, they are also entered in the formulary, but all of them are added based on their safety, quality, and their availability as well. So 3 points we make sure before procuring any medicine or selecting. So based on the safety, quality, and availability. 3 points we make sure. Second is comes the procurement. So procurement, the pharmacy takes care of this aspect. So they only procure medicine from the approved vendors which have been approved in our hospital. They make sure that quality assurance report is available to them. Let's say if a batch is causing problem in patients, for example, let's say injection monosep. If injection monosep is causing adverse drug reaction in 5 patients, then what we do is we call the pharmacy and we take a quality assurance report of that particular batch. Then we analyze this report. So if there is any discrepancy in this report, then we recall the medication. Then they will recall the whole batch of the medication in the hospital. So that's how this helps us in preventing the adverse drug reaction, and it makes sure that there is no counterfeit medication which is being used in our hospital. So to ensure the patient safety, the procurement part, quality control reports, we are checking them for minimizing the adverse drug reaction. So whatever medications in our hospital that we are receiving, they have a GRN number. Particular medicine has a GRN number, which is good receipt number. So or this receipt number make sure that we can track the medicine where it was dispensed from where it was procured. Everything can be tracked down using this GRN number, the batch, expiry date, and the lot number. All of these things are verified by the pharmacy. And if there is a vaccination or medicine which are heat sensitive, or you can say they have to be kept in a temperature controlled environment. So temperature logs are there in the pharmacy. So we also sometimes when we go for the audit, we make sure to check these temperature logs as well, so that the cold chain is maintained and these medicines maintain their efficacy as well. And for the dispensing part, we train our hospital pharmacists to make sure that they are validating the prescription based on the essential elements of the prescription, like superscription, patient's details are there, the doctor's details are there, registration number, signature, stamp, and the medication details which must be there as part of the minimum requirement of the prescription. We make sure that these requirements are met in the prescription and they are dispensed based on the patient's need. And we make sure that the double check is being done for the high alert medications. So not just for dispensing part, for administration part as well, we have a policy related to high risk medicine. Whenever nursing are going to administer medicine, high risk medicine to the patient, two staff verify it. The one staff nurse and another staff nurse, two people verify this order, and in the treatment chart they will sign. Two people will sign in the treatment chart to make sure that patient is receiving the right medicine at the and there is no harm to the patient, because high alert medications have very low therapeutic window, and high alert medicine also contain LASA medicine. LASA means look alike sound alike medicine. So those medicines who look alike and sound alike, we check them, and two people verify this order in pharmacy as well and nursing staff as well before giving it to the patient. So we make sure the patient is receiving the right medicine and the dosage is correct as well, so that there is no harm to the patient, because high risk medicine can cause high harm to the patient which can result in death as well. So these you can say practices that we do in our hospital to ensure the patient safety as well. So let's talk about storage at cold chain and inventory control. So as a clinical pharmacologist or clinical pharmacist, you will be given some responsibility to internal audits or audits of the hospital related to pharmacy as well, not just pharmacy and the storage of medicines in the hospital. For example, an ambulance, you have to do audit, you have to check the crash card, you have to check how the medicine is stored in the wards as well in the ICU, and the narcotic storage you have to check. the you can say chemo medicine storage, you have to check. Sorry. So you have to check all of these medication storage as well. So until unless you are not familiar with the storage, you can say requirements and the practices that we do, you will not be able to do this audit properly. So what we do, we first of all is we check for the environment. We make sure that temperature and humidity monitoring is being done with the alarms and action limits are there. So there is a temperature control sheet which is pasted in the fridge or wherever the vaccines or cold medicines are stored. So we check the temperature control chart whether the cold medicines are between 8 to 8 degrees Celsius, and if there is any variation, then we make sure that the action is taken against that case, and the devices are calibrated and there is no improper handling of these medications. Because let's say for example, if insulin is dispensed from the pharmacy and cold storage is mentioned, the cold storage is there, but if this medicine is reaching out from pharmacy to the floors, to the ward, and the sister is giving medicine to the patient, but they are not storing this medicine in the fridge, or you can say if the medicine is coming from pharmacy to ward and there is a gap in this and there is no temperature control there, so this is going to degrade the insulin, and if you are going to give this insulin to the patient, there will be poor glycemic control. So the temperature management must be there, and when we analyze the medication errors or when we analyze the therapeutic failure of the patients, then these things come up. So these are the basic things that we should be aware of. The temperature monitoring and control is a very important aspect related to medicine, not just storage or procurement. This is regarding dispensing or you can say administration as well. Segregation of medicine should be done. Lassa medicine, I told about the look-alike, sound-alike medicine. So they should be stored diagonally, and there should be a list of Lassa medicine, look-alike, sound-alike medicine. There should be a list, and according to this list, this medicine should be separated apart from the normal medicine, so that this medicine cannot be dispensed easily and there is no patient harm to the there is no patient harm, because look-alike sound-alike medicine can cause harm to the patient. For example, the patient was going to be given for example tranexamic acid, let's say, and a tranexamic acid and bupivacaine both look same. Let's take another example, vitamin K or adrenaline, both injection look same. So if they are stored say in a single storage area, then there is a good chance instead of giving vitamin K, patient can be given adrenaline, and this can cause tachycardia, it can lead to patient death. So this is a classical example that we see. So we may have to make sure that wherever medicines are stored, Lassa medicines are separated. Hazardous medicine, hazardous medicines, or you can say hazardous materials, they have to kept separately, and there should be a you can say hazardous sheet which should say how if these are there is a spill of this hazardous medicine, how it is going to be controlled. Because hazardous substance, if they are not handled properly, they can lead to patient harm, they can lead to staff harm as well. So the material safety data sheet, we call this MSTS sheet, this has to be there in the procurement or storage area, and hazardous medicines has to be kept separate, or hazardous chemicals, you can say, not medicines, chemicals you have to keep separate. And for narcotic medicines are kept in double lock and key, so that they are not misused, and there is a narcotic register. So whenever the narcotic medicines are used, this entry is done in the narcotic register, and two people verify whenever the narcotic medicine is you can say when it is discarded. So if you give, for example, if the patient is in pain, for pain management we give them fentanyl or morphine. So if you are going to give fentanyl, let's say 50 mcg you are giving for pain management, and the vial is coming of 100 mcg, then 50 mcg is remaining. So this 50 mcg has to be discarded after 48, after 28 hours or 24 hours. This medicine has to be discarded because this medicine loses its efficacy. Second thing, there is a chance of misuse of this medicine as a narcotic medicine. So this has to be you can say it has to be discarded, and this discarding should be done in presence of two witness. And second thing is the record of this discarding process should be mentioned in the narcotic register. And uh, you can discard narcotic medicines in the running water, or you have to either dilute it 1,000 times. That's how you have to make sure that these storages are done properly in the hospital. Now, temperature control I have already talked about. So, and inventory control practices, you might be aware of the inventory control practices that we use: ABC analysis, VD analysis, FIFO rotation. So, all of this thing has to be maintained by the pharmacy itself. And if there is improper inventory control, there will be supply chain issues, there will be, you can say, stock out situation. And the emergency medicines, they must be always available in stock, because you never know whenever there is a disaster, if is no proper inventory control, there will be shortage of the medicines. So inventory control practices has to be done by the pharmacy. So you can cross check it as clinical pharmacologist. Now comes the safe dispensing and patient counseling. Uh, Many aspects are, you can say, they are covered by the hospital pharmacist and clinical pharmacologist or pharmacist as well. So number one is do patient review, prescription review that we do. So whenever you are doing a prescription review as a clinical pharmacist, make sure to check its indication, whether there was indication of medicine was there in that treatment chart, or you can say whenever the patient was admitted in their emergency assessment sheet, indication must be there. The dose and route must be there. There should be no therapeutic duplication. So, for example, let's say if the patient is being given PPI and there is another medicine which is given. For example, let's say patient was given pantoprazole and ranitidine as well. Both serve the same thing, but there is a therapeutic duplication. But you can stop one medicine so that another medicine can cover it, and this will save the patient's cost, the inconvenience that occurs to the patient because they have to give in through the injection. And third thing is that it is going to give you a chance to show your intervention. Second thing that you have to look after is the interaction. So drug-drug interaction is an important thing. Sometimes the patients are on multiple medicines. The polypharmacy is a big problem in the clinical role. So, if the patient is on the more than three medications, then you can check this for drug-drug interaction. You can use Medscape, or you can say you can use Lexicom. Online drug databases are there. You can check for drug-drug interaction. Then you can do the intervention based on that. And if it is not possible for you to check every treatment chart, you can remember few drug interactions. Then you can implement them in your practice. Allergies are important aspects. Most of the times, what happens for the OPD prescriptions, there is no allergy mentioned in them. So you have to ask the patient about the allergies. If you are doing patient counseling, you have to ask your patient about the allergies, whether it is related to food or it is related to medicine. Allergy can be related to food or medicine as well. So you have to check for them as well. Make sure that it is mentioned in the patient's file or the discharge summary or the prescription. These are mentioned so that patient does not suffer from any harm next time if they visit any healthcare setting for any problem. If the patient is not aware about the allergy, there is a good chance the doctor might prescribe them the medicine which they are allergic to. So that's how you can enhance the patient safety to make sure the allergy is there in the treatment chart or discharge summary or the prescription. Second thing is the labeling. So, if there is an allergy to the patient, then there should be an allergy band put it on them in the hospital. A red allergy band is there, the medicine name is mentioned on it. So that from mistake, no nursing staff giving them this medicine. And all the high risk medicine, they have to be highlighted with a red label. A red label is there, and it has to be put it on the high risk medicine so that everyone is available that aware that this is a high risk medicine. And sometimes if it is not possible to put the red label, then the high risk stamp can be there, which can be put it on the bill. So certain practices helps in ensuring patient safety and the drug storage as well. Second thing is, whenever the infusions are prepared, if infusions are not labeled, This is a common practice that we see in the hospital. If your infusions are not properly labeled, then there is a good chance that this medicine can be given wrongly to the wrong patient as well. For example, let's say injection meropenem you have to give through infusion over 3 hours, and the drip rate must be 20 drops per minute, or you have to ensure 30 ml per hour, and you have prepared it in the 100 ml vial. Then if these details are not mentioned on the label of the infusion that the nurse has prepared, then there is a good chance she is going to give the medicine faster, which can cause toxicity to the patient or adverse drug reaction. Or so these things must be there. Infusion levels are a good practice that should be there in the hospital. Then comes the counseling part. So whenever you are counseling the patient, make sure to follow certain aspect that you are delivering information to the patient in their local language. Number one, the most of the clinical pharmacists do mistake that they use technical terms because patients do not understand their technical terms. They might not be educated, so you have to use the local language, easiest available. You have to use words which are easily understandable, and you have to ask them to teach you back how can you, like for example, can you show me how to take this. For example, what I saw in my hospital, there was a patient who was not aware of how to use their inhaler properly. Because of this, they were having problem in controlling their asthmatic attacks. And there was one more patient who was taking insulin in the wrong way, so they were not aware of how to take insulin properly. So these are the things that you can do in your ward rounds. Whenever you are going in the hospital, you can counsel the patient on how to use medicine, what is the duration of medicine, what is the purpose of this medicine, what can be the side effect, what can be the important point that you should remember, and how they are going to retain this medicine, retain this information. So you can use pictograms, images which can guide your patient on how to take this, because after the counseling there is a good chance patient will forget the most of the information. So they must be given some material. Pictograms are the best material for the patients to understand it, and you can ask them to show you what they have learned from this session, how can take medicine, how to use this, and you can ask them. So these are some counseling points you should remember whenever you are counseling your patient. And number one thing, apart from this, what you can do is you have to inform your patient about your red flags. For example, if I am taking insulin, then I should be counseled on the hypoglycemia. If there is a low sugar, what I have to do. And most of the times, patients they have a hypoglycemic episode and they fall, and because of this fall, they have to be hospitalized in the hospital. So to prevent these falls, you have to counsel the patient on hypoglycemia, what they have to do. If they are getting up suddenly, if they are getting any, if they are getting any, you can say drowsiness, they are going to fall, then they should get down, take rest, call someone, and they should take their sugar or pill or candy. They should take, you should have with them. So these are the points that you should counsel your patients on. Last thing what you can do is you have to do dose adjustment of the patients. For geriatric patient, pediatric patient, renal hepatic impairment, and for the pregnancy patient, you have to make sure there is no contraindicatory medicine that is being used in your pregnancy patients. So for pregnancy patients, what you can do is you have to remember the FDA pregnancy categories, and you have to check the prescription for the this medicine, and you have to check their pregnancy category of individual medicine which the patient is using, so that your patient is safe. Okay. And for renal hepatic impairment, you have to use Cochrane, you have to use child pug score. If the child pug score is more, then you have to adjust the dose. And for the renal impairment, you have to adjust dose based on the Cochrane Gold equation. And for obese patient as well, you have to take care of. So you have to make sure that you are calculating the ideal body weight before calculating the dose adjustment in the obese patients. So you have to be familiar with these formulas. You have to use them to calculate dose of the patients. And You have to implement it whenever you are analyzing the prescription or treatment chart in the ward or the hospital. So you have to follow these practices that we follow in our hospital. Let me give you an example of dose adjustment. There was a patient in our hospital which was having effects of photosensitivity, or he was seeing double vision, and after some time he was complaining of having loss in his vision. The patient was using voriconazole injection, and the voriconazole injection can cause reversible vision loss, but the patient was suffering from the candidiasis, candida infection. Patient was suffering from candida infection. So it was a problem, and we counseled the patient, and we consulted with the doctor that the patient had the risk to benefit ratio we decided, and we tried to adjust the dose up to the patient's tolerant level based on their MIC, and this medicine was given to the patient for at least 1 to 2 weeks. Then it was changed from IV to oral, and after 1 or 2 weeks, the patient's vision loss was recovered, and the patient was counseled. So there was no, you can say, there was no incompliance from the patient side, and the infection got treated. The patient got better. The side effects were minimal. So that's how we can do the intervention. That's how you can utilize your clinical knowledge to help the patient. This is the good pharmacy practice is all about. Now let's come to clinical pharmacy and medication review part. So review part I have already told you, but there is one more aspect related to the medication reconciliation, which is very important. So whenever patients are shifted from one location to another, these are called transition points of care. So whenever a patient is shifted from ward to ICU or ICU to ward, you have to check their all medications which they were given previously and which are they are using currently. So you have to check all of this, uh, and to make sure there is no therapeutic duplication, there is no omission, and there is no medication error. All of this you have to check, and then you have to make an accurate list of the patient's medicine. So this activity we do in our hospital in 3 stages. Whenever a patient is transferred from emergency to ward, and whenever patient is transferred from ward to ICU or ICU to ward. Third, when we do is whenever a final discharge summary is made. So whenever a final discharge summary is made, we check it as well for medication reconciliation. So at 3 stages we do medication reconciliation. So this helps preventing any medication errors, adverse drug reaction, therapeutic duplication, any drug related problem. Number two, what we do is we do medication review for dose adjustment. I have already told you this aspect for drug interaction, dose adjustment, therapeutic drug monitoring, and if a patient does not require any medicine, we de-prescribe it. We stop this medicine. Number three, what we do is we do ward round preparation, participation. So make sure to do ward rounds with your consultant in the hospital. If it is better to do a pre-round before going to ward round, so that you are aware of the, you should, what you should do is you should go to any ward or ICU, just simply go there, check all the case files, note down your intervention, and whenever consultant is taking around, you should inform them about your findings logically based on your patient's condition and the available guidelines and your recommendation. That's how you can do your intervention. And you should, whenever you are doing ward round, you can also monitor for the adverse drug reaction to the patients. So, and how you can monitor for the adverse drug reaction, you have to review the progress notes or the continuation sheet where the doctor monitors the patient's progress. So you can check for any reaction in that, or you can check for certain medicines. So for example, you can check for Avil or F-Collin, and these are the medicines that are now commonly given to prevent the adverse drug reaction or to treat the adverse drug reactions. So you can check for these two medicines, Avil or F-Collin, and in your patient treatment chart, if patient is given Avil F-Collin, check why it was given. It's in onco patient. It is also used in many uh, patients who require uh, any inflammatory process. If they have it, these are given. So you can check them, and Number four is to make sure that you are taking ward rounds on daily basis. So this will enhance your clinical knowledge and it will serve the purpose of enhancing your patient care as well. Number four is you have to, whatever, if you have done an intervention, you have given any such finding to your physician and the physician has changed the medicine, then you have to follow up your patient. Follow the whether the outcome was achieved or not. Let's say you have adjusted a dose in any case and you have adjusted the dose to minimize the toxicity in the patient. So if you have done this intervention, you have to check whether the effect was there or not. So make sure to follow up your patients after doing intervention. This is the part most of the clinical pharmacists never do it. After doing intervention, they forget their patient, they never follow up on their patients. You have to follow up. This is the best practice that you have to do. Now comes the ethics, confidentiality part, and controlled substances. So, as a clinical pharmacist, you have access to the medications to make sure that all of these medications are used genuinely. They are not used for any other purpose. They are intended to make sure to protect the confidentiality of your patient. Never share any patient related detail to anyone. Okay. You can discuss the case with your colleagues, but make sure to not disclose the confidentiality of the patient. Number one mistake that the most of the clinical pharmacists do whenever they are reporting the ADR. Whenever you are reporting any ADR or medication error, make sure to never mention patient's name, full name. You don't have to mention in the ADR form. You have to mention patient's initial name only. For example, my name is Ankit Gaur, and you have to write any ADR form for me. Then you will not mention my full name. You will mention my name as AG. Something called AG, my initials. You have to mention my initial in the ADR form. Or if you are analyzing medication error, then in the medication error form, you have to mention my initial only, not full name. This will protect my confidentiality. You can use my UHID number or MRD number, but you should never use my full name. The patient's full name, you should never use it. And whenever you are counseling your patient, make sure there is a private space available for patient counseling. If you are doing bedside counseling, then make sure that there is a private space available to you, because the patient is going to disclose uh, some history which might be confidential to them. So, in order to make sure that this information is kept between you two, that make sure there is a private space available and there is no one there. And if a counseling room is available, it is much better. Second thing is consent. So always make sure if you are doing any clinical research, patient consent must be taken. And in your master's degree or MD, if you are doing, then you have to do for your research. Then if you are doing any research, you have to take patient's consent. So even if you are giving any service to your patient, you have to ask their permission. Okay. Third thing is the controlled substances. So make sure that all of the narcotic medicines, all of the high risk medicines, and they are stored properly. High risk medicine has to be stored in single lock and key. Narcotic medicine has to be stored in double lock and key. So these practices are followed. So we have to make sure. And conflicts you have to avoid, because conflicts can occur between the doctor with the nurses as well. So you have to give respect to all of the healthcare professionals. Make sure there are no confidentialities. There are no conflicts between all of you, and your there is no conflict of interest if you are doing any clinical research. So all of things you have to consider. Now you can utilize some safety tools in the hospital to minimize medication errors, adverse drug reaction, and to enhance our practice. Number one is called digital prescription. So if there is a digital prescription, there will be legible handwriting, there will be no medication error, and allergy medicines are mentioned. If allergy are mentioned and interaction are checked online, then there will be patient safety. Second thing is barcoding. So if the medications are barcoded, and then there will be less chance of any medication error. Or you can utilize decision support systems such as I told you, Medscape, Lexicom, all of these online apps that you can utilize for checking renal dosing, IV compatibilities, and antimicrobial stewardship. You have to follow your antimicrobial policy of the hospital. And telepharmacy can help in doing patient counseling and taking patient consent as well. So quality assurance, for quality assurance, you have to do root cause analysis of the incidents for medication error, adverse drug reaction, or near miss. You have to do corrective and preventive action. So if there is any incident, we have to do the corrective action. For example, if there is any medication error, we will check for why it happened, how it happened, who were involved, when they were involved, and what was the sequence of the event. Based on that, we take corrective action. Whether if the patient was given wrong medicine, the doctor was informed, the patient was monitored closely. This is the corrective action. Preventive action, we educate the staff, and if we make sure if there is any risk involved, the risk is minimized. For example, if high risk medicine was given to the patient, for preventive action, we educate the staff to follow the high risk medicine policy. Storage of medicine is available properly. Everything has to be cross checked, and you have to document your data. Whatever you are doing, you have to document it so that you can present it somewhere, and your what you can measure it, you can show your impact. If you are not documenting it, there is no purpose of doing any practice. You have to document everything you are doing. If you are documenting it, you can present it in the meetings, so there will be impact of your work. If there is no documentation, there will be no impact. Third thing is continual professional development. You have to do journal clubs, simulations, you have to do credentialing, you have to maintain your logbook, so and you have to attend seminars, and you have to continuously learn throughout your life by attending seminars, workshops, conferences, doing journal clubs, all of these things to ensure that you develop competency and you are able to practice properly with confidence and there is no patient harm from you. So there is a case study. This is just an example. So a refrigerated insulin was dispensed after 3-hour power outage. So patient returns in the emergency department with the hypoglycemia and erratic control. So this is the problem. What happened here was the insulin is a cold chain medicine. It has to be. It is temperature sensitive. The temperature must be controlled. There was no power backup. Because of this, insulin was degraded, and this got is given to the patient. This caused hypoglycemia. So what can be the issue? The cold chain was not maintained. The documentation was not there. There was no counseling on storage of the hospital pharmacist, and there was some breaches. So what you can do is you can take corrective preventive action, and based on that you can prevent your patient's harm in the future as well. So summary and the key takeaway is the good pharmacy practice means safer system, proper clinical care, ethics, and continuous learning. So all of these things has to be taken care of whenever you are doing your good pharmacy practice. Whenever you are practicing in the hospital, you have to take care of all of these things. Systems are safe, clinical care is provided, ethics are maintained, confidentiality is maintained, and there is continuous learning. So this is what pharmacy practice is all about. Thank you so much. Any questions?
A wonderful talk. And since they started with a very high note onto various ethical prospects of the clinical pharmacy, and sir, you have touched upon every aspect of the practice which is done as per NABH standards, and definitely the pharmacist working in the setups of hospitals, either it is India or abroad, and in various vulnerable populations, either pediatric, geriatric, pregnant, and lactating women, and this is the really need of the hour. So you have covered very wonderfully all the prospects of the pharmacy practice, whereas the presentation was very much impressive, which the ones I have got a lot of personal messages as the feedback of compliments regarding this presentation, which fulfill their requirement of knowledge. The day which is holiday today, straight of it, the people are have attended as participant. So on behalf of ISF College of Pharmacy and Internal Quality Assurance Cell, in association with Climate Research Solutions, we have organized this. We are organizing this since last 3 days. Today was the fourth day, and since the session was so nice, there are no such questions, Dr. Ankit. And sir, if such questions do arrive, definitely come to know. And I can see the coordinator, Dr. Madhav Divedi, is keen to ask one question. So, sir, please go ahead.
Okay, well, thank you, Dr. Ankit Gaur. And one of the coincidence, my PhD guide was also Gaur, Dr. Kalpesh Gaur. I want to remember him with your title. And well, really inspiring your one-to-one explanation. And my question is not any technical issues. As you are working in a hospital and you are explaining these things, what is your opinion that suppose how much human resources are needed to cope these situations? And as we are organizing this good pharmacy practices, we need lots of pharmacy practice people to control these things. Why? Because these are very important, I mean to say, the important features that we have to add on in the hospital. Because I have seen practically in my life, I have in a Delhi hospital, I went for my mother ailments. I saw the very bad things. I cannot take the name and all the things. We need a lot of personnel to do this thing. Even single ward need a single clinical pharmacist to control this thing. My question is, as per your opinion and experience, how you can imagine the how much clinical pharmacist is needed for the safety and efficacy for every Indian citizen? Please
Yes.
give this answer, sir.
Yes, sir. Sir, based on my opinion, what I have seen is, uh, if you want to make sure there is safe and rational use of medicine in the hospital, there should be a patient pharmacist ratio. Clinical pharmacist and patient ratio must be there. What is the current practice is there is only one clinical pharmacist in the hospital, and in some hospital there are only two clinical pharmacists. So all of these clinical pharmacists cannot look after every treatment chart, every prescription, every OPD prescription, or every case summary when the patient is discharged. So in order to make sure that there is a safe ratio, the safe ratio of clinical pharmacist and patient must be there. We can refer to the Indian public health standards which are there, and they give a ratio of 50 to 1. But from my opinion, this ratio should be 25 to 1. In the wards, there should be one clinical pharmacist and 25 patients. Okay, and for the ICU, the ratio should be almost less. For there will should be one clinical pharmacist and 10 ICU patients must be there. So only in this way you can prevent the patient harm, because all of the cases the clinical pharmacist has to review. They have to do ward round and constantly keep on monitoring the patient's clinical condition, and they have to constantly give their input. So if you are saying that individual pharmacist has to placed in the ward, it can be done, but the pharmacist ratio and patient ratio must be taken care of, because in general ward, the general ward might have 50 beds, and one clinical pharmacist for 50 beds, it is not acceptable. So the ratio must be there. The clinical pharmacist patient ratio must be maintained. So that's how we can.
Ultimately, you are saying that our clinical pharmacist profession have a lot of future is coming,
Yes, yes,
and the
that's
sun
right.
have to be rise for the safety of the Indian people,
Yes, sir.
because as the practicing all over the globe. And previously, our head of department, Dr. Saurabh Processor, told, and we have to work for this, sir. And thank you so much. And I am hand over to the Saurabh Processor.
Yes, sir. Thank you, Madhav sir, for such a wonderful question, and Ankit ji for the answer. And I have one more question, Dr. Ankit, that particularly what is the role of MPharm pharmacology and pharmacy practice in the hospitals, in particular current practice scenario, as you are already in this segment for last 6 to 7 years, you can have a comment on it.
Sir, in the hospital, we have at least you can say three major areas where MPharm pharmacy practice or pharmacies all can work. Number one is clinical pharmacy or clinical pharmacology, this role that I am doing currently. Second role is pharmacovigilance associate. That if a hospital, as per the NABH has given a mandate, and the Ministry of Health and Family Welfare has also given a mandate that all of the medical colleges has to be registered as ADR monitoring center. So all of these center need a pharmacovigilance associate. So where the pharmacy practice graduates can work. Number one is clinical pharmacist, second is pharmacovigilance associate, third is the clinical research department. Most of the prominent medical colleges and big tertiary care hospitals have a dedicated clinical research wing. So there they need a clinical research professional. So as a clinical research associate, these graduates can work. So these are the three major areas where these people can work.
Excellent. Last one more comment. So I saw your profile bio sketch stating the medical device adverse the material vigilance program of India. So you are also coordinating the same center.
Yes, sir.
So what kind of clinical expertise and the job roles are coming ahead in the future for PharmDs and MPharm practice, particularly in material vigilance?
Sir, in matter of vigilance, same for just like pharmacovigilance associate, the families are working on and pharmacy practice are working. They can work as matter of vigilance associate, and the drug inspector role for medical devices and for the same for drugs. So all of these roles are available. In my hospital, I work as medical device monitoring center coordinator, MDMC coordinator. So what my role here is to make sure there is no medical device adverse event related to any medical device. If there is any event related to it, we report it to the MVPI. Second, we make sure there is a corrective and preventive action in place. So let's say, for example, if a X-ray machine is giving the wrong X-ray interpretations, and this is leading to a wrong diagnosis to the patient, which is causing patient harm. So what we will do, we will collaborate with the biomedical engineer, and he will go to the company, and that the company will take the corrective action, and based on that we will convey our findings to the MVPI, and then we have to make sure there is no repetition of this process, and we present this finding in the we have a committee, causality assessment committee. Every month we do this meeting with the medical administration staff and the top management. So we discuss all these cases, and we make sure that the patients are not harmed and these events are not happening again, and the reporting is done on regular basis, and the feedback is given to the prescribers and the radiology department or whatever the department is concerned. All of these things that we do. So as the MPharm and pharmacy practice individuals, what they can do is this role they can also take up, because most of the pharmacies or MPharm pharmacy practice graduates as a clinical pharmacist in the hospital, they will be given responsibility of ADR monitoring center coordinator, AMC coordinator, and they can take additionally this responsibility of MDMC coordinator, because biomedical engineers they cannot do causality assessment, because we are the one who are trained in doing this. We can use Naranjo scale, Uppsala monitoring center, they have given their own causality assessment scale. So we can do causality assessment, we can present the finding, we can take corrective preventive action, we can guide them, because biomedical engineers cannot do patient assessment. But this is what we can do. We can go to the patient, we can analyze how this event has impacted them, and then we can present our findings and take action further. So this is the role that we can fill as well.
Yeah, excellent horizons of the pharmacovigilance and the drug safety and the patient safety. India has emerged in the last couple of 2 decades. Not only pharmacovigilance and material vigilance, but also hemovigilance program of India, cosmetovigilance, herbovigilance, biovigilance, cosmetovigilance, even new clinical trial rules. So kindly accept Dr. Ankit our greetings and the certificate of speaker as appreciation. You have taken time from your really busy schedule to share the knowledge, and knowledge is wisdom. It is a continuous process. What you are learning, you are sharing to the peoples, are definitely the one concept. Today you have enlightened many clinical minds, and I definitely understand this kind of presentation ignites the cerebral heights individually. So in the future also we will have you, I will take your services, as resource persons in person also physically sometime. So thank you so much once again, Dr. Ankit from Department of Pharmacy Practice at ISF College of Pharmacy in association with IQAC and Climax Research Solutions. We are organizing this 8-day good pharmacy practice awareness lectures. So you are a part of this very executive series of pharmacy practice. So once again, I would like to thank you from all stakeholders of ISFCP. Thank you so much.
Thank you, sir. Thank you.
So thank you, San sir. Thank you so much for your wonderful presence throughout the session, and Dr. Madhav for coordinating, and Parneet ji